name is Daniel DeBerry. I'm a student respiratory therapist here at Baptist Health Sciences University. And today what I'm going to be sharing is how to perform a successful extubation on a patient who is intubated. So first, the environment. The endotracheal tube should be removed in an environment in which emergency equipment and the appropriate trained healthcare providers with airway management skills are immediately available to assist with the patient. Some indications for the removal of an endotracheal tube. The airway control afforded by the endotracheal tube is deemed to be no longer necessary for the continued care of the patient. Some subjective or objective determination of improvement of the underlying condition impairing the pulmonary function of gas exchange capacity or both is made before extubation. Now, to maximize the likelihood for successful extubation, our first set, the patient should be capable of maintaining a patent airway and generating adequate spontaneous breaths. Now I'm going to review with you some contraindications to extubating your patient. There are no absolute contraindications to extubation. However, some patients may require one or more of the following to maintain acceptable gas exchange after extubation, like non-invasive ventilation, CPAP, high-inspired O2, or you may have to re-intubate your patient, depending on the situation given. Now, hazards and complications of this, there are some, and let me review them with you. Hypoxemia after extubation may result from, but is not limited to, failure to deliver adequate FiO2 through the natural upper airway, acute upper airway obstruction, development of post-obstruction pulmonary edema, bronchospasm, laryngospasm, development of atelectasis, or lung collapse, to name a few. Now, let's get into how this procedure is to go. So the procedure for oral tracheal extubation is as following. Prior to extubating your patient, the following should be done. Assess the room, assess the patient, get into it. So the equipment, what equipment do we need? So we have a suctioning apparatus right here. We have a Ballard that is currently hooked to the patient. We need a 10 ml syringe or 12, manual resuscitator with the appropriate sized mask, and dependent on if ordered, keep on standby just in case racemic epi and normal saline for if the patient develops any post-extubation stridor from removing the tube. You need some water-soluble lubricant and your intubation equipment, such as your laryngoscope blade, Mack and Miller, tape, syringe to deflate the cuff. Now let's move on to the second step. We've got our supplies in case we have to re-intubate for any reason. Towel. You want to place a towel across your patient because when you pull that tube out, you do not want any secretions to get on the patient, and it just makes for easy removal of the tube, and you can discard it in the waste container when you're done. I've got my patient in the position. What do I need to do next? So the second step, we need to suction the endotracheal tube and pharynx to above the cuff. Suction before extubation helps with preventing aspirations of secretions after the cuff is deflated. Now, we should be prepared to suction the oropharynx. I'm just using this for demonstration, it's not hooked up for suction. So it's suction out the mouth on both sides. Now I'm going to go ahead and give this patient 100% FiO2 because extubation, it's a stressful procedure that can cause hypoxemia and unwanted cardiovascular side effects. And to help avoid this, that's why we give 100% prior to extubation. Step 4, let's see, we're going to deflate the cuff and do what's called a cuff leak test. So the 10 ml syringe is attached to the pilot balloon. All the air is withdrawn from the cuff while the RT should listen for an audible leak around the tube. So we've got the 10 ml syringe, and we would just take a stethoscope and we'd place on the side, right? And we're listening to that audible leak around the tube. And if no audible leak is present, the RT should reinflate the cuff and discuss with the physician how to proceed. So, now let's remove the tube. The tape or holder that's securing the device, the tube, is removed. The technique used to remove the tube should help avoid aspiration of pharyngeal secretions and maximally abduct the vocal cords. Clinicians use one of two different techniques to accomplish this. In the first method, a large breath is given with a manual resuscitator. In this instance, we just, on the vent, give the patient a manual breath prior to extubate. So that large breath is given and the tube is removed at peak inspiration when the vocal cords are maximally abducted. And in the second method, the patient coughs and the tube is pulled during the expulsive expiratory phase. This technique also results in maximal abduction in the vocal cords. And so that's going to take us into the step 6. So apply appropriate oxygen and humidity therapy. So post-extubation stridor can occur, as I mentioned earlier. So we want to have on standby some type of aerolized. Okay, so moving on to step 6, we're going to apply the appropriate oxygen and humidity therapy. Patients who have been receiving mechanical ventilation may still require O2 therapy, usually at a higher FiO2. Other patients may require some O2 because this is a stressful procedure. If humidity or aerosol therapy is indicated, most clinicians suggest a cool mist immediately after extubation. Now, assess or reassess patient. After extubation, auscultation is performed to check for good air movement. Stridor or decreased air movement after extubation may indicate an upper airway problem. Next, the patient's respiratory rate, breathing pattern, heart rate, blood pressure, and SA2 are checked. Mild hypertension and tachycardia immediately after extubation are common and resolve spontaneously in most cases. The patient is encouraged to cough with assistance as needed because laryngeal edema may worsen with time and stridor may develop. Racemic epinephrine for nebulization should be available. Arterial blood gas values should be sampled and analyzed as needed. The most common problems that occur after extubation are hoarseness, sore throat, and cough. These problems are benign and improve with time. A rare but serious complication associated with extubation is laryngospasm. Post-extubation laryngospasm is usually a transient event, lasting several seconds. If laryngospasm occurs, oxygenation can be maintained with a high FiO2 and the application of positive pressure. If laryngospasm persists, a neuromuscular blocking agent may need to be given, which necessitates manual ventilation or reintubation. Because the vocal cords have limited function during the intubation period, they may not close fully as needed when the airway has been removed. Now, to avoid aspiration, oral feedings, especially liquids, should be withheld for 24 hours after extubation. Patients may aspirate liquids even with an intact gag reflex. So in the instance that extubation failure occurs, which I am defining as the sudden need for reinsertion of the airway because of airway problems, which often occurs within 8 hours of extubation. Aspiration and edema are the most common problems. If the patient also is mechanically ventilated, reintubation may be required for worker breathing issues unrelated to the airway. So now that you have all the facts, let's get to it. Performing my cup leak test. Alright. And now I put the air back in. I heard air around. So now what I'm going to do is I'm going to talk to the patient, let them know what's happening. So today we have Mr. Daniel with us, and we're going to be pulling this tube out. So Mr. Daniel, my name's Daniel DeBerry. I'm a student respiratory therapist, and today we're going to get you off this vent and we're going to get that tube out of your mouth. So when we go to do that, I'm going to deflate a cuff that is keeping the tube in place within your airway. When I deflate that cuff, I'm going to need you to give me the biggest cough you can. And I'm going to pull the tube out as you're coughing. I'm going to put it right here. So when you're ready, I'm going to deflate the cuff and pull the tube out. Patient, Mr. Daniel told me that he was ready. So right now, I'm just removing the tape. That's holding the tube in place. Alright, Mr. Daniel, I'm about to pull that tube. Make sure I have my yarker in place. Alright, on the count of 3, I'm going to pull the tube, Mr. Daniel. I'm going to need you to give me a big cough. Ready? 1, 2, 3. And now the tube is out. I'm going to suction the patient and get no secretions. So now that I've got the patient extubated, I'm going to put the patient on oxygen and see how he responds now that he's extubated. And that is extubating your patient after being intubated. Thank you.
I want to thank the viewers who watched this video, and this video was made possible with the resources provided by the Respiratory Care Department led by Program Chair Ms. Kira Anderson. Thank you so much, and with the help of Ms. Antoinette Beckley. Have a good day.